Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Robert Wood Johnson Foundation, a Medicaid-Public health partnership to improve health and control costs, early lessons from the CDC's 618 initiative. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located in the drop-down menu of the toolbar at the top of the screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope you'll take a moment to do this. I will now turn the webinar over to Stephen Summers, President and CEO of the Center for Healthcare Strategies.
Thank you, Travis. It's a real pleasure for me to be here today. It's for this webinar on this unique national initiative. I'm really excited on behalf of ourselves and our core partners, the CDC, the Robert Wood Johnson Foundation, CMS, and ASTO, and others, to welcome you to this call. We will have on our agenda today a brief remarks from Hillary Heisman about the Robert Wood Johnson Foundation's reasons for investing in this initiative. We'll also hear from my colleague, Maya Crawford, about with an overview of the CDC initiative to enhance Medicaid-Public health collaboration and implement evidence-based prevention strategies. There'll be information on the project's goals, examples of recent activities and successes, and the introduction of a new set of Medicaid-Public health teams from states and a locality. There will be two presentations focused on policy accomplishments from the first phase of 618, which kicked off in early 2016. We'll hear from Lillian Drix from Rhode Island and Christiana Goulardi from South Carolina, and then there will be a Q&A session. The next slide will provide for you just an introduction of today's speakers. I've introduced them already in describing their remarks. And the last slide that will now appear on your screen is a picture of the the Center for Healthcare Strategies work and our National Nonprofit Policy Center, which is dedicated to improving the health and healthcare of low-income Americans. And we work primarily with states, the federal government, and the healthcare delivery system, stakeholders in that system, and public health to improve care through shared learning and technical assistance. And that's exactly what this 618 initiative is all about. So with that, I thank you, and I am going to hand this over to Hillary Heisman from the Robert Wood Johnson Foundation.
Hello, everyone, and thank you so much for your interest in 618. You know, even with changes in the fields of healthcare and public health, there are some things that I feel pretty confident about. My colleagues and I at the Robert Wood Johnson Foundation, we feel confident that it's good for state Medicaid and public health agencies to be able to take advantage of each other's strengths and to coordinate more. I feel confident that Medicaid, as well as other insurers, play an important, potent role in keeping people healthy, and 618 helps with those. So RWJF thinks states, especially, you know, Medicaid and public health within those states, play an enormously important role in building a culture of health in this country. And we value what you're trying to do, what we're all trying to do here, and the skills and powers that states have. 618 is one of a variety of approaches that the Robert Wood Johnson Foundation is supporting to be able to help states to build relationships and skills and leadership and use data and get lessons from others to be able to be successful on their path. So it is a pleasure to get to work with CHCS as well as CDC and CMS and all of the important partner organizations engaged in this effort. So I'm glad you're either already participating in it or are interested in learning from 618, and we are eager to learn from you. So thanks, everyone.
Thank you so much, Hillary. And this is Maya Crawford. I'm a Senior Program Officer at the Center for Healthcare Strategies. And CHCS, thanks to funding from the Robert Wood Johnson Foundation, works closely with the CDC to help both state and local public health agencies and payers implement 618 interventions. So today I will be presenting a high-level overview of the CDC's 618 initiative, which will include a description of the roles that Medicaid and public health participants play in this work. We'll note some highlights and accomplishments from the first round of work that we have helped to support. And then I will announce the next round of Medicaid public health teams that CHCS, CDC, and our partners will be engaging with in the year to come. So to kick things off, here's an overview slide of CDC's core strategic directions. And the 618 initiative fits squarely in the third strategic direction there at the bottom around strengthening public health and healthcare collaboration in the context of today's rapidly transforming health system. It also aligns very well with working to address the leading causes of death and disability. So the 618 initiative was conceived of, developed, and launched by the CDC, and CHCS is really pleased to be partnering with the CDC to help a variety of states and other participants engage in this work. So here is the CDC's Prevention and Population Health Framework. And this is also what's kind of affectionately referred to as the 3 buckets of prevention. And this framework describes the population health prevention that can be categorized both in clinical and community settings. This just provides some general context for how CDC envisions prevention work and different opportunities to categorize it. So bucket 1 includes traditional clinical preventive services, and an example of that would be an immunization or colorectal cancer screening test. Bucket 2 encapsulates more innovative services that extend care from the clinic to the community. So these would be services delivered directly to individuals, but in community settings. And an example of this would be the use of community health workers to assess asthma triggers in the home as a way to augment asthma control in a clinical setting. And then bucket 3 includes community-wide interventions delivered not to individuals, but to entire populations to benefit the health of larger communities. And an example of that would be a school-based program to increase physical activity among children. The CDC firmly believes that health will be improved by focusing attention to all 3 buckets. And the 618 initiative really fits within buckets 1 and 2. So it's a little more focused on the individual level. But we are currently working with CDC and with our partners to think through opportunities to leverage this bucket 1 and bucket 2 work into more community-based opportunities and think through, again, how to move a little more towards the community-wide strategies. The CDC developed the 618 initiative to promote the adoption of, by healthcare purchasers, payers, and providers of evidence-based interventions that both improve health and control costs in the relatively short term, so that being within 5 years or less. And the name 618 comes from the initial focus on 6 high-burden health conditions and 18 evidence-based interventions. But it's important to note that CDC is engaged in an ongoing evidence review process to ensure that the conditions and interventions reflect the most up-to-date health and cost evidence, which means that over time, the number of conditions and interventions may change. And today's presentation focuses on just one lane of 618 work, which is to engage public payers, and specifically state Medicaid agencies, in conjunction with their state and local public health colleagues on implementing 618 interventions. But CDC is also working to promote 618 strategies with commercial payers as well as healthcare providers. And the idea over time is to engage an increasing number of stakeholders in this work and to move this initiative nationwide. The 618 initiative has 2 core goals. The first is to improve health and control costs using evidence-based prevention strategies. And the second is to establish sustainable links between public health and healthcare purchasers, payers, and providers as partners in population health improvement. And here's a graphic depicting the 6 high-burden health conditions that are covered under this initiative. So these conditions are tobacco use, high blood pressure, healthcare-associated infections, asthma, unintended pregnancies, and diabetes. And these conditions were chosen because they meet the following criteria. So 1, they affect large numbers of people. 2, they're associated with high healthcare costs. 3, there are evidence-based interventions that are available that we know of to prevent or control these conditions in a short time horizon. 4, they're associated with interventions that can be implemented on a relatively large scale, so in many cases either at the state level or by a health plan. And number 5, the evidence-based interventions can be implemented by different facets of the healthcare sector, so by purchasers, plans, payers, providers, and others. And I'll just note that round 1 of the 618 initiative just focused on 3 of the 6 health conditions, so on tobacco, asthma, and unintended pregnancies. But the second round of work that we are kicking off now is focused on all 6 of the health conditions. The 18 in 618 represents an initial set of 18 evidence-based interventions that are associated with the 6 health conditions. And you can see those here on the screen. And I just wanted to note that I feel like one of the real benefits of how 618 is structured is the fact that it presents this very clear and concise and concrete menu of evidence-based policies and programs, which means that for any new participants in this work, there's kind of no need to spend valuable resources on trying to figure out which particular policy or strategy might be most effective in addressing a particular health condition. But that background research has been done already by CDC experts and has been presented here. And this specificity is also really helpful during the implementation phase of 618. So when multiple sectors or partners are working together to advance an intervention, everyone is very clear about what that intervention is, what it incorporates, and why. And CDC, in addition to having this clear menu of interventions, also has a set of evidence summaries that presents some of the background data and research supporting each of the specific interventions. So while anyone can benefit from the 618 initiative's current set of resources, which includes the intervention list that we just saw and the evidence summaries that I just referenced, CDC has also been working with us here at CHCS, thanks to an investment from the Robert Wood Johnson Foundation, as well as CMS and a variety of other partners to provide more intensive technical assistance and support to a set of Medicaid and public health teams as they implement their chosen interventions. And this is what we're calling the proof of concept for this work, with the idea being that by providing some very targeted and individualized support to these teams, we can better understand the needs, challenges, and opportunities associated with implementing these 618 interventions on the ground. And our goal is to then use those learnings to craft an expanded set of resources, templates, and learning opportunities that would become available to a much wider audience in the future. So the yellow on the map indicates the initial set of Medicaid and public health teams. So there were initially 9 states participating, and this work launched in February of 2016. So these initial states were Colorado, Georgia, Louisiana, Massachusetts, Michigan, Minnesota, New York, Rhode Island, and South Carolina. And then the orange on the map indicates the most recent and second set of teams that we're engaging with. This includes 6 new states, and those are Alaska, Maryland, North Carolina, Nevada, Texas, and Utah, as well as the District of Columbia and Los Angeles County. And so we are working directly with these teams to put together action plans laying out what they want to accomplish under the initiative, and then to work directly with them on some of the implementation processes, as well as providing direct technical assistance based on their individual needs and some group learning activities, including webinars and peer-to-peer calls. So now you can see 3 of the core focus areas of 618 activities. So the first of these is around coverage. So some of the interventions are focused on enhancing coverage of a particular benefit. This could be at the state level through a Medicaid state plan amendment or at the health plan or payer level. So for example, one of the tobacco interventions is to expand access to evidence-based tobacco cessation treatments, including individual, group, and telephone counseling and FDA-approved cessation medications. So in the first round of states, one of the teams we worked with decided to remove all copays for tobacco cessation services through a state plan amendment. And you'll also be hearing in a short amount of time from representatives from Rhode Island and South Carolina who are also working to enhance Medicaid prevention benefits, but doing this in partnership with their Medicaid health plans. The second focus area is on utilization, and this is targeting healthcare providers and making sure that providers understand what prevention benefits are currently being offered under Medicaid, and then working to educate them or provide incentives or training opportunities to further enhance how they provide those benefits. So for example, a state focused on preventing unintended pregnancies by removing administrative or logistical barriers to long-acting reversible contraceptives under 618, specifically focused on training providers about how to appropriately insert and bill for these long-acting reversible contraceptives. And then the final focus area here is around uptake, and this is the consumer-focused lane of work in which teams can work directly to ensure that Medicaid members or other consumers are aware of prevention benefits. So again, for example, in the round one set of states that we worked with, a number of them conducted communications campaigns that targeted consumers through mailers and billboards, as well as social media and other online platforms to ensure that they were aware of the full range of tobacco cessation benefits available through Medicaid. So now you'll see a chart here that depicts the different skill sets and areas of expertise that the Medicaid and public health agencies participating in 618 bring to this work. And I think this has been just a really nice example of cross-agency collaboration. So again, for participation in 618, we requested that any state wanting to participate and receive the direct technical assistance from CHCS and CDC have both leadership buy-in from Medicaid and from public health, and have representatives on their team from both of these agencies. And kind of the unique feature here is just the fact that, in many cases, teams, often did not have a lot of history of collaboration across these two agencies, but 618 helped to bring these partners together. And through this, the different respective agencies were able to contribute unique yet complementary skills to this work. So for Medicaid, here are some examples of the types of expertise or skills that they bring. That includes authority over benefits and coverage, the ability to establish and track health quality goals, to collaborate with federal and state policymakers, and access to a range of clinical and quality data. Whereas on the public health side, some specific skill sets include disease-specific expertise, on-the-ground knowledge of particular barriers that consumers or others may have in accessing resources, expertise in intervention design and implementation, as well as experience in larger scale campaigns to get the word out about available programs or policies. So really, the unique contributions of these different agencies, I would say, really help to accelerate the work of 618, with each side bringing this different set of skills, resources, and connections to the effort. So there are a number of benefits for participating in the 618 initiative. And the first, again, would be the opportunity to either establish or to strengthen cross-agency partnerships. So the CDC conducted a qualitative early effectiveness evaluation, and findings from that suggested that the participants in 618 saw this as a real benefit, both for enhancing and accelerating the work that they were doing on their 618 interventions, but also as a means to strengthen relationships in other areas of work too, and have some of that relationship building go into other aspects of their work. So another benefit of participation is the opportunity to better align prevention goals and strategies with other forms of health transformation, and specifically with state payment reform activities and goals. So a number of the states we're working with have really thought strategically about how 618 fits into initiatives like the State Innovation Model Initiative, and how they can work to incorporate 618 into state health improvement plans or Medicaid waivers that are working to promote value-based payment strategies. So we really see 618 as an opportunity to think about how investments in prevention can align with other work that's currently happening to move towards population health improvement and payment mechanisms that reward quality and health outcomes. Additionally, states will see over time both improvements in health and costs, and we are working to support the teams that we're currently working with and how to track progress in their work and begin to think about those metrics that will enable them to track changes in health outcomes and costs. As I noted, for the participating teams, there is access to targeted technical assistance through CHCS and CDC, and we are continuing to look through opportunities to share resources and tools publicly, so that even if a particular stakeholder is not currently engaged in 618, they will have increasing access to some of the learnings and tools that states have produced or that the technical assistance team has helped to create. And finally, a big piece of 618 thus far has been shared learning. And this is something we're working to enhance across participating teams through technical assistance webinars and peer-to-peer information exchanges. And again, are hoping to package some of those state-developed resources and learnings into publicly available tools that we will post on our websites over the next year or so. And then finally today, just wanted to give a couple of examples of accomplishments from the first round of teams that participated in this initiative. So here we see that a number of teams initially conducted some baseline coverage and utilization assessments to better understand how benefits were being offered either at the state level or at the health plan level. States then worked to make changes through state plan amendments or through Medicaid health plan contracts. A number of states also worked around changes in billing or payment. One state in particular created some legislation to change scope of practice to enable new types of providers to offer tobacco cessation prevention benefits to Medicaid members. And then finally, as I alluded to before, a number of the teams that we've engaged with over the past year really focused on enhancing provider and member education about prevention and about available prevention benefits under Medicaid. So for more information about the 618 initiative, we encourage you to go to cdc.gov/618. As I said, the list of interventions and the evidence summaries are available on the CDC website. The CHCS website also has some additional resources, including webinars and blog posts. And we are hoping to continue to post new resources and tools on these websites in the months and years to come. So with that, I will now turn things over to our state presenters, and we will first hear from Julian Drix from the Rhode Island Department of Health, who will talk about his experience working under the 618 initiative to promote asthma control through a pediatric asthma home visiting program. So Julian?
Great, thank you, Maya. Can everyone hear me? Good to go?
Yes.
All right, so I am the asthma program manager in Rhode Island. I've been working with the team here within the Department of Health at higher levels of leadership, as well as at Medicaid for our work around controlling asthma. And we'll just do my best to share a quick kind of summary and overview of both what we've been doing before 618 started, the foundation that was in place, and what we've been working on since receiving the technical assistance through 618. So, let's try to advance my slides here. There we go. So as was discussed earlier, of the 18 evidence-based interventions, we in asthma have been really focused in Rhode Island on the fourth of the interventions for asthma, which is for expanding access to evidence-based home visiting with either licensed professionals or qualified lay health workers. The intervention that we have uses both, and I will get into that shortly. And referring to the three buckets of prevention with the CDC model, we definitely see this as fitting very squarely within bucket 2, taking the clinical work and extending it into the community, which is really important for asthma, given how much environmental factors within the home have an impact on asthma. Here is some data. Everything we do is data-driven, and this is a claims data report that we published in 2014. That was a bit of an expanded asthma surveillance project. This one, rather than using just hospital discharge data or BRFIS survey data, used asthma claims data from all the major insurers, both Medicaid and commercial as well in the state, and looked at both prevalence, so any asthma claim, whether it's an inhaler or a hospitalization, to be able to look at, address level hotspots across the state of asthma prevalence. And then also at the neighborhood level, being able to look at some hotspots, and we looked at ER outcomes, hospitalizations as well. So there's a lot of maps in the full report. Just drawing some attention to these ones to see just how strong the asthma disparities are that we see in Rhode Island, similar to many places across the country. It's very much concentrated in our core cities. Then the map on the right, you can see is the same map for our 4 core cities, and you can see those same disparities are reflected in neighborhood to neighborhood within the areas. And the dots you see on the map are public housing authority buildings or Section 8 vouchers. So you can see that where these asthma hotspots are is very aligned with housing issues, which again, in the world of asthma, makes sense. Here's a quick description and overview of what our intervention is. So this is the Home Asthma Response Program, referred to as HARP. It's an evidence-based intervention which has been under development and since 2011 and based on previous evidence-based models for asthma home visiting as well. It utilizes both a certified asthma educator as well as a community health worker to conduct 3 home visit sessions, both to assess patient asthma knowledge, trigger exposure, provide asthma self-management education by the certified asthma educator in the home environment, while also being able to do some instruction and education around identifying asthma triggers in the home and how to remediate those triggers and remove asthma triggers from the home environment. And it includes some cost-effective supplies, such as a HEPA filter vacuum cleaner, some integrated pest management supplies, food storage, cleaning supplies, mattress covers, et cetera, which are really crucial for families to be able to effectively address asthma triggers in the home. The HARP model has been built on a number of pre-existing partnerships. So we work with Hasbro Children's Hospital, which is the primary pediatric hospital serving the entire state, and then as well as 2 other health centers, St. Joseph's Health Center, Thunder Mist Health Center, and our partners in Massachusetts, Health Resources in Action. And I'll talk briefly about them in a little bit. We have worked very closely with the 618 initiative, so there's a pre-existing model in place, and then through 618, we've had a much closer relationship with Rhode Island Medicaid, working with both CDC and CMS for national level policy expertise, and then the technical support both from Center for Healthcare Strategies, as well as some data analysis support from Georgia Tech to help with building our business case. And this has been really important because there's so much going on in the healthcare reform landscape with our managed care organizations, what we call in Rhode Island, our version of ACOs are accountable entities. We have 2 levels of SIM expansion within Rhode Island, population health goals. We're also investigating and looking into a pay for success feasibility study. So there's a lot going on, and then having the technical advice and support is really helpful to really figure out how the intervention that we have and have been building in place will fit in with this changing landscape. One of the big areas that was very helpful was really getting some support around, we've been doing ongoing data and analysis, and we have a lot of data from multiple sources, and figuring out how to align it and make our messaging very concise, and really the best way to frame our messaging when we're approaching Medicaid and managed care organizations has been really critical. Just as some brief background about the types of data that we were working with and using and had in place. We have participant survey data from everyone who's been through the program. So this is the asthma control test, quality of life surveys, tracking missed days of school and work, symptom levels. Then we have the observed data from the asthma educator or the community health worker around the presence of asthma triggers, behaviors in the family, and how those things have changed over the course of participating in intervention. And then we have our outcomes data, looking at claims data, so looking at hospital utilization, the costs related to that, pharmacy, office visits, et cetera. To make things more complicated, we also had separate funding streams. So we had to combine both our CDC funded, which is starting for the initial HARP launch and throughout time, as well as CMS funded as part of the New England Regional Asthma Innovation Collaborative, which is the project coordinated by Health Resources in Action with across 4 New England states, 9 provider groups reaching over 1,000 participants, and had some aligned evaluation across all of those groups. So that was a really incredible project and really helped gather some more data to make a stronger case, but it was separate data, even though it was the same intervention, same partners, a separate data set, separate evaluators, and made it a little bit difficult to combine. And then in combining all this, talking about, the difference between the initial HARP and then the CMMS funded NEAC project expanded across the region, the various levels of outcome data, a big challenge was keeping it concise. So what we did after that was work on combining all this together into a business case. So the next few slides are just snapshots of a single-page infographic that focuses on what we are able to do and the different sections on this on our business case condensed down to a single page. So obviously we focused a lot on the economic case, looking at cost savings and return on investments. We separated out the overall HARP participants who had to have at least one asthma ED visit within the prior year. But then we also looked at a subset of high utilizers who had to have 2 or more ER visits or an asthma hospitalization, which was a smaller number, but we saw stronger outcomes there as well. So you can see the data on the screen there. We saw consistent reductions in both ER visits and hospital costs. We saw within the higher utilizer subgroup both a higher percentage reduction as well as a higher total reduction, which you can see both in the percent change and the dollar sign change. And this here is just the participant data, but we did also look at comparison groups and the general population, and this is where Georgia Tech really was helpful as part of the 618 initiative, and being able to show that we also outperformed what would be an expected reduction, the standard regression to the mean. We decided not to end up including that data on our one-page infographic because it made it much more complicated, and there's a lot of different layers to that. But we did examine this as part of our bigger business case. We also looked at our return on investment overall based on the cost of the intervention and then comparing that to the outcomes and the cost savings, showing a positive ROI. And we looked at it both for overall asthma costs as well as the ER-specific ones. We really zeroed in on the hospital utilization costs because that's what the intervention is designed to reduce and prevent preventable ER visits. However, we did also want to look at the overall asthma costs because those are also costs that go into it, but we obviously want to see an increase in costs for doctor visits and medications, and we did see strong improvements on increased control of medication use, which is really critical for preventing emergencies. So even though that's an increased cost and slightly reduced the ROI because of that, that's also another quality improvement outcome that really matters to the healthcare sector and really is part of bringing together public health and healthcare. So through that NEAC intervention that was CMS funded, we were able to see that the asthma medication ratio, the HEDIS score for participants, increased from 32% to 46%, which is really critical. That's a measure that is very difficult to move, and the comparison case that we looked at basically stayed flatline with that. So that was a major improvement there and raised a lot of eyebrows with Medicaid, with health plans. And then here's some of the other outcomes we also looked at: improving of asthma control, improved quality of life, reduction of triggers, reduction of missed school and work days, increased asthma action plans. But we found that the HEDIS improvement for quality improvement was really one of the most essential pieces with that. Here on the right side of your screen, you can see what the overall infographic looks like, how we were able to condense all of that information into one piece. The blue box in the bottom left-hand corner that I blew up so you could see a little bit better was based on an additional set of data that was directly from Medicaid, coming from our partnership there, looking at how many children would be eligible based on, who would be eligible for the HARP intervention, both within the general group as well as this higher utilizer subset, and how much are they costing per person in total currently, so that we could, in our discussions with Medicaid, talk about, how big are the savings that are seen here, and how can we move forward on coverage and reimbursement. So that's where we are now. Wrapping up to where we are today, Medicaid has been a really amazing partner with this. They've been very impressed with the results. They've been following this for a number of years, but through 618 have been much more active participants and partners. We've had a number of meetings with leadership, and Medicaid did sign off on making this a covered benefit. It was going to be just covered out of plan in order to get it approved quicker and a little bit easier. But there were some recent changes within our an unrelated state budget crisis from some other issues that came up. And so when it went through the legislative review process for the budget, any new items were automatically told no. So because it was a new line item, that is no longer an option. But Medicaid is still very invested in making this a covered benefit, and our next step is working on integrating it into our MCO contracts. Looking at value-based purchasing. We also have this parallel track of working with partners looking at a potential pay-for-success arrangement, which I won't get into here. That's a separate piece, which would add on some additional payments, hopefully, for home-based remediations and housing improvements beyond the things that a family can do themselves, but is strongly aligned with what we're doing with the HARP model. And so we're not at the finish line yet, but we've made a lot of progress. A key has really been being flexible and developing the collaboration over time. And working with Medicaid on this and with our partners at the national level has really brought us leaps and bounds from where we were when we had started. And we feel we are getting very close to soon having a covered benefit that's available for all eligible Medicaid pediatric members. Last slide is just my contact information. Feel free to follow up if you have any questions or want to email me. I can share any of the reports or data that I mentioned here, and there'll be time at the end for some Q&A. Thank you so much.
Excellent. Thank you so much, Julian. Great to hear about your efforts under 618. So I'll now turn things over to Christina Gallardi, who works at the South Carolina Department of Health and Human Services, for her presentation about the work that South Carolina has done under 618 around tobacco control. So Christina?
Hello, everyone. I'm Christina Gallardi, and I'm a project manager in the Policy Planning and Evaluation Department within the Division of Health Programs at CHHS, which is the Medicaid agency in South Carolina. And I'm excited to share a little bit of information with you today about our efforts to build relationships with our internal public health agency in the state, and also moving forward to improving our tobacco cessation benefits for our Medicaid members. So just to give you a little context for our work, I wanted to share some background about the landscape of South Carolinians covered by Medicaid. In South Carolina, Medicaid largely serves pregnant women and children. About 60% of our beneficiaries are in this group. However, there are about 380,000 adults with full benefit Medicaid coverage in South Carolina, and most are covered by one of 5 managed care organizations. And smoking rates among these adults are much higher than the general population. From surveillance data through a public health agency, we see that about 19% of South Carolinians are smokers overall, but from patient surveys through our managed care organizations, approximately 33 to 40% across managed care organizations are smokers. So this really highlighted a need for intervention on tobacco cessation and preventing tobacco use, which drew our attention to this area of the 618 initiative. And in taking a look at the 618 initiative, it really drew our attention to the immediate policy areas that we needed to address tobacco use that would have the potential for greatest impact. And those were first to expand access to evidence-based tobacco cessation treatment, both through medication in collaboration with individual, group, and telephone counseling. Second, to remove barriers that might complicate access to covered services such as cost sharing and prior authorization that just might be barriers for both providers and beneficiaries. And third, to promote the use of those treatment benefits. So once we took a look at these interventions that were recommended through the 618 initiative, there were still some challenges that stood in the way of achieving those policy recommendations from DHHS's perspective. And we knew that these changes needed to be made, but we just didn't necessarily know how to move forward. One was that we knew anecdotally that there was inconsistent coverage of tobacco cessation services across managed care organizations. Not all of them had consistent coverage of the FDA-approved medications and did not have consistent offerings of different counseling services. Second, we weren't really aware of what the fiscal impact of any coverage changes, particularly affecting our managed care contracts, would have. And in preliminary conversations with our actuaries, they had expressed difficulty in being able to capture the value of changes to tobacco cessation benefits that could be captured within a one-year rate cycle. And finally, we just needed to gather some buy-in from relevant stakeholders, in particular our managed care organizations and their medical directors, if we were going to move forward with any changes on our policies. So we recognized that these were challenges, but we didn't necessarily have a mechanism to push us in the right direction. And that's where 618 really helped us jumpstart the right partnership with DHEC, which is the Department of Health and Environmental Control, our state public health agency. So healthcare and public health, like many states, are housed in separate agencies in South Carolina. And really, 618 highlighted the imperative to leverage resources across our agencies, especially for chronic conditions and preventive interventions like trying to reduce tobacco use. So 618 really pushed us toward collaboration, and this slide really reiterates Maya's slide earlier in this presentation about the things that we were able to leverage and combine across our agencies. Our public health agency really brought together the why for why we needed to intervene with preventing tobacco use and their disease-specific expertise around tobacco use, both at an environmental level and at a clinical level. And in our development of different relationships with our managed care organizations around this topic, it was really critical for us to bring DHEC in early in the conversation to provide that context in the presentation to the managed care organization about the importance of these efforts and to describe the 618 initiative. And this really helped us gain a lot of support from our medical directors. And then in terms of our intervention, healthcare and DHHS was really the how in terms of our provider network and bringing together our managed care organizations and taking a look at our claims data in terms of how any changes to benefits would happen and be shared. One other useful thing with 618 is that it provided the structure for getting started by helping our agencies to create an action plan. So our agencies came together last year for the 618 opening conference, and as an anecdote, we often share the public health officials and Medicaid staff rode together in the car to Atlanta, and this was one of the longest times that they had spent together and were able to talk about opportunities to collaborate and resources that we had to share. So it was just a really neat opportunity for our staff to get to know each other better and to really partner not just in the conference room. So in putting together an action plan at this conference, the staff highlighted the importance of working in two different areas. First, to enhance tobacco cessation, medication, and counseling benefits through our managed care organizations. And second, to better leverage our funding match available for Medicaid beneficiaries who use the quit line. This was just not something that South Carolina was taking advantage of, although some other states have already implemented this. So these were our two key areas of focus, and within those we outlined specific actions to help us move towards those goals. So first, in taking a look at the changes to our benefits through managed care organizations, DHEC was helpful in helping us develop a tool for a policy scan of what our managed care organizations were offering to our beneficiaries. The 618 initiative and the CDC also provided some research that we put together into a very targeted request for actuarial analysis for cost offsets to our managed care contracts, since this was something that we had not been able to move forward with previously. And then we've also worked with DHEC to help establish a data sharing agreement to match Medicaid beneficiaries who use the quit line, and now we can track that information and pair it with our claims data. And we have also been working on developing a memorandum for a reimbursement process to get that Medicaid matching funding to support the program. So we're very excited to share that as of July 1st of this year, the 618 policy recommendations in terms of the tobacco cessation benefits will be adopted by DHHS. This means that all full benefit Medicaid members in South Carolina will have access to all 7 FDA-approved medications with no prior authorization or copays, and this includes medically appropriate combination therapies. We're also in our policy bulletin that we have been sharing publicly, providing a strong referral to the tobacco quit line, which is housed within DHEC and run by that operation, to really encourage leveraging that opportunity for free counseling with skilled behavioral health coaches. And finally, we have added the ability to use codes for individual or group physician counseling within the Medicaid program as well. So in terms of what this means for a change to our benefits, previously pregnant women did have access to this comprehensive benefit, but now it is available for all full benefit members. Again, this is helping us achieve consistent coverage across our NCOs and really helping providers feel like they can prescribe whatever is best for the member rather than trying to follow different reimbursement rates and mechanisms between NCOs, and also removing barriers to access on the side of the beneficiary by having no copay. So we're looking forward to the path ahead. Even though July 1st is coming up, there's still more that we know we need to do for this process of implementation. We're finalizing our data sharing agreement related to the quit line match funding, and next we're moving forward to more effective promotion and monitoring of these cessation services. We're planning to meet with our DHEC epidemiologists to help set up our monitoring framework for this. And we're also looking forward to shifting our focus to other 618 health conditions. In addition to continuing to monitor our efforts in tobacco, we'd like to turn our focus to diabetes as another high-burden health condition, particularly with our Medicaid beneficiaries, and will really benefit from being able to follow this path to success that we've had with tobacco. It's been really confidence building and sort of a mastery experience for our staff, and we feel like we can follow a similar path that we've trod for working towards changes with diabetes. And in terms of promotion and utilization of the cessation services, again, we're leveraging our partnership with DHEC to help us put that policy more effectively into practice. And so DHEC is really providing some great technical assistance for us. They have already met with the MCO communications work group to provide information about different technical assistance that they can offer, some training for providers on how to effectively deliver tobacco interventions that can be billed under the counseling codes, providing different sample materials for MCOs to tailor to reaching out both to providers and beneficiaries, and providing assistance with linking EMRs to their quit line so that a provider can see whether or not a beneficiary took advantage of the opportunity to call the quit line as a free service to them. So I think this is another benefit for us in that we're partnering both for materials within our state but also across states that we've been able to get sample materials through the CDC and CHCS for other states in their communications outreach. And finally, the next area that we're looking forward to partnering with DHEC on is blending our data sources to better capture information about the impact of our policy change. So it's very hard to get accurate data on tobacco use simply through diagnoses codes and through claims data because they're not always accurately captured. But now we really have multiple resources that we're able to leverage. Some surveillance data at the state level with CRFSS and the Adult Tobacco Survey, which will be adding a Medicaid, an indicator for Medicaid status for the next year of the survey, and then also taking a look at our claims data. And now our match with the data with the quit line will give us a more comprehensive understanding of the services that our beneficiaries are taking advantage of. So we're continuing to tweak our policy implementation and promotion process, and we'll continue to monitor it over time, but we're confident that we'll be able to move forward on this pathway together. So please feel free, if you have any other questions about our efforts in South Carolina, to contact me, and I look forward to any questions that come up later in this call.
Excellent. Thank you so much, Christina. Great to hear from you. So before we turn it over to Q&A from the audience, I know we have representatives on the line, both from CDC and from CMS, and we would like to hear from them about their respective involvement in this initiative, both in terms of how this work under 618 is benefiting state and local participants, but also how it's working to enhance cross-agency collaboration at the federal level. So I would now like to turn things over to Kristen Bruce-Wallace at the Centers for Disease Control and Prevention to hear a little bit from you about the CDC's perspective on this work.
Great, thanks, Maya, and thanks for the opportunity. So just a couple of comments for us. For one, there traditionally had not been such strong linkages or collaborative work across CDC and CMS, and 618 really sort of brought that partnership, or strengthened that partnership, if you will, so that we had a better, maybe a stronger collaboration in the way that we approached the implementation of these prevention interventions, and that we had sort of the payment piece, the payment and the science together when we began working with these states. So one of the things, even since the beginning of the 618 work with the states, which was back in February of 2016, we sort of made this prerequisite, if you will, to have the states come to the table with both public health and Medicaid leadership in terms of the way that they were approaching this, the 618 work. And so our partnership at CDC became sort of that connection, the CDC partnership and the CMS partnership, especially through the Center for Medicaid and CHIP Services, since that is a partner, and Deirdre Stockman on the line, you'll hear from her as well. But that partnership was seen, really, we found to be pretty critical in the way that we were delivering technical assistance to the states. So we felt like you couldn't sort of talk about implementing science without how the payment policies could be addressed and what needed to be in place in order to be able to sort of implement. And so I really liked the way Christina mentioned in her talking in her presentation earlier around sort of what public health, public health provided the why, and then the healthcare, the Medicaid side provided the how. And I think that was very much similar to how it worked at the federal level. We had this rigorous body of science that really showed some evidence around cost and health savings around these interventions and practices, but how do we sort of get those covered and allow for the implementation? And I think that's been a critical piece, and we've really seen that connection grow, both through the policy office here where we sit and through the scientific divisions and representatives throughout the agency.
Great. Thank you, Kristen. And as Kristen noted, we also have a representative from CMS on the line, so Deirdre Stockman from the Centers for Medicaid and CHIP Services. So Deirdre, do you want to say a few words about CMS's perspective on the 618 initiative?
Sure, and thanks for the invitation. I really want to echo what Kristen spoke to, all the points that Kristen just spoke to. We've really been pleased to partner with CDC and CHCS and, very importantly, all of the states on the 618 initiative, because it aligns closely with and complements our work here at the Center for Medicaid and CHIP Services and the Division of Quality and Health Outcomes in particular, the work that we do to improve quality of care delivered to people enrolled in Medicaid and CHIP and to improve health outcomes for our beneficiaries. And the 618 initiative has been one of the ways, and our partnership has been one of the ways to really expand what has been an increasing focus here in our division on improving delivery of preventive services to people enrolled in Medicaid and CHIP. So by partnering with CDC, and the Center for Healthcare Strategies and others, we've really been able to extend our reach in terms of the number of states that we can work with and the number of health issues that we've been able to engage with states on in our prevention work. And I think with respect to the 618 participating states, many of them have considered over the last year, and the next group will continue to consider over the coming years, making changes to the healthcare services that they provide in their Medicaid program, as you've just heard, to address the target conditions. And so, again, as you've heard from Julian and Christina, all of the 618 states, I think, really use the opportunity to help them better understand the evidence behind what services are most effective and how to effectively engage healthcare providers and beneficiaries so those services are delivered in a high-quality way, as well as thinking about the evidence that can inform, also changing the way that states pay for certain Medicaid services to better align payment with their quality and outcome goals and health outcomes in particular. So we're really looking forward to continuing this collaboration and to further expanding the number of states that we're able to engage with to improve delivery of the really high-impact services that lead to better health outcomes for beneficiaries.
Excellent. Thank you so much, Deirdre. So at this time, I would encourage participants on the webinar to pose any questions that you may have through the Q&A box or the chat box. So we will be collecting those and working to respond to them. But we did have a few questions already come in, so I will kick things off on the Q&A portion. And by posing the first question, I think, to Kristen at CDC. So this question is, what is CDC's vision for 618 moving into the future? And so can you talk just a little bit more about given where things are currently, where you see this work going and kind of what you hope to accomplish under 618 in the next 1, 2, or 5 years.
Sure, and thanks, Maya. So again, for us, 618 is a really, we feel like it resonates with states across the country. Many states are working in this sort of realm in one way or another, looking to implement prevention practices. So what we've been doing last year and this year in terms of sort of our process is trying to learn from some of the examples that states are experiencing in how best to look to implement and to sort of overcome barriers and sort of accelerate that process. So as Maya mentioned earlier, we begun the second year of learning more from some different kinds of states, a local health department, a big city. And what we'd like to do is take those learnings and be able to sort of expand those learnings, if you will, and create an opportunity for other states to learn from those experiences. So our plan is to look to scale, obviously, or maybe not obviously, but the very sort of intense technical assistance that we've been able to provide for these couple rounds of states. We wouldn't be able to provide that across the country, but we're hoping that there will be a number, and there have been a number of tools and processes that are applicable to other states in similar situations. And so we're working together with the RWJ support and a partnership with CHCS. We've been able to sort of build this library, if you will, of resources. And so the future, what we're looking to do is take these learnings and in the next, probably 2018, look to create some tools that other states can come in and learn from the experiences, and with the hope that that can help accelerate their processes for implementation, overcome barriers maybe more quickly by using sort of the learnings from the other states. So the idea is that we can create an environment that will accelerate the process and be usable across the country in terms of coverage and uptake and implementation of these interventions.
Thank you, Kristen.
Sure.
Okay, so we had a question come in that I think could be directed towards Julian, Christina, or Deirdre. So we'll see who wants to take this one on. And the question is, wouldn't the removal of authorization requirements generally be expected to increase costs, or were authorizations approved most of the time anyway? So I think this is maybe specifically for Christina to kick things off. If you were thinking about analyzing the removal of prior authorization for the tobacco cessation benefit, how did you make the case, and was that associated, that removal, with any increase in costs?
So as I mentioned briefly, we had put together a request for actuary consultants to consider the cost of making these changes to our benefits, and there was a slight increase to our per member per month rates for the coming fiscal year to accommodate the cost of these changes. However, it was within an acceptable amount for South Carolina to move forward with implementation of the policy change. And also, we did include some background research about the potential for cost savings over time, especially related to reduced disease later in life, and how that might be able to be captured even within a one-year rate cycle. And that was based on some of the research that we have been provided from some of this assistance. I hope that helps answer your question.
Thanks, Christina. Deirdre, anything you wanted to add to that? Okay.
Sorry, it took me a second to get off mute. I think I would just add that the goal is to improve access to and delivery of the most effective interventions to help people quit smoking. And so there's you know, again, I think the case to be made that if people can get access to those medications and successfully quit smoking, that the benefits will ensue after that, whereas putting up more barriers just reduces the number of quit attempts and successful quits. So, but it's, you know, it's an important consideration. I think certainly the 618 states, among others, you know, think a lot about what the impact of changing some of those authorization requirements might be on utilization, and just make the calculation that having the health impacts is what they, you know, what they're looking to do.
Great, thank you. Okay, so another question we got was around whether we're seeing 618 being used at all by Medicare as a payer, and any potential for Medicare and public health collaboration under 618. So curious if Kristen from CDC or Deirdre from CMS has any reactions or thoughts about that question.
This is Kristen. I can start, and I'm sure Deirdre will have things to add. So I would say that the best example is around the diabetes prevention programs, and that just the recent process for the rule change around Medicare coverage has made this a pretty important time for that condition and the coverage. So we're beginning, certainly the division has been doing a bit of work, quite a bit of work, I should say, around the Medicare coverage process. And so that is something that we, probably the work that we're, the lane of work for that has been most with the commercial insurers. And one of the things that I don't know that we've made clear or mentioned early on, and actually I think my address in her opening remarks or her opening presentation is that we also have, this is, we're talking today about the state Medicaid work with 618, but we sort of have a mirrored lane with a set of large insurers in terms of the work that they're doing around implementation of these interventions. And so the Medicare book of business with those commercial insurers has become part of that 618 work. And I know Deirdre has worked closely with our Division of Diabetes Translation around that, and so I'm sure she has things to add.
I can just very briefly note that, and make sure to give credit where it is due, that Medicare and the quality improvement organizations have been working for quite some time on a few of the 618 conditions, even predating 618, around healthcare-acquired infections and high blood pressure with million hearts. But I think that the question is a great one that we've certainly learned from the experiences and that Medicare has led going before, and there are probably more opportunities to facilitate sharing about successes from that work with people, states, and other entities participating in 618.
Great, thank you. Okay, we have a question here for Julian in Rhode Island. And it says, as a Medicaid MCO, what is the best way to establish a reimbursement process or contact with statewide health department performing asthma in-home assessments? So it sounds like here the Medicaid MCO is interested in making that connection directly with the state health department. So what kind of recommendations would you have for making that connection to establish reimbursement?
Sure. So I think it really depends on state by state, and asthma home visiting as a evidence-based model can be done a number of different ways, and there's various versions and models of the various types of interventions that happen in different states. I think the first step would be to find out if the state is one of the CDC-funded state asthma programs, in which are funded in over half of the states in the country. And if so, to reach out to the program manager or director at the state level in the health department to find out what the current state of asthma home visiting is. Even in states that are not CDC funded currently for state asthma control program, there can still be asthma home visiting interventions. Sometimes they are housed through a hospital, sometimes within a health center, within an ACO, community-based organizations. And there's a variety of models of how they have been paid for at the MCO level. And some MCOs actually have their own program and kind of build it into you know, a visiting nurse type of intervention or bringing community health workers on staff. So there's a number of different ways that it could be approached. So I would be happy if you wanted to email me and follow up on my contact information and let me know what state you're in. I could find out for you who the contact person would be and find out what models already exist. I know Michigan was another one of the 618 states that has quite a number of MCOs that are reimbursing for a model there called MATCH. And so in Michigan, for example, there is this evidence-based model that kind of on an MCO by MCO basis will set up a, it's an evidence-based model that various community providers can provide, and has been established with different contracts between MCOs and various kind of approved providers at the community level. So that's one model. There's models that happen within a county or within a city, some of which are statewide. So there's no one kind of best fit, but I think there's a lot of options and there's a lot of evidence out there showing how effective it can be at improving health outcomes and reducing costs, which is exactly why 618 is focused on that. So for general guidelines, the CDC website for 618, the evidence base there shows the research and the various kind of summary of existing interventions and financial outcomes. So that's another resource that you could turn to that has much more detail about what the various options are. I hope that answered the question.
Great. Thank you, Julian. A question now for Kristen at CDC. And this question is, when will CDC or CMS focus on community-based strategies, and which holds the greatest promise? I'm wondering if you could speak to CDC's work maybe on addressing bucket 3.
Sure. So here in the policy office at CDC, we have a sister office and a sort of a sister initiative called the High Five, and that is an initiative that is dealing very much with the community-based kinds of interventions, focused on sort of policy changes that affect communities. And so if you're thinking sort of the next phase, or from 618 sort of is in that bucket 2, and then High Five makes the leap to the bucket 3. And there are some of these that intersect in terms of the conditions. Certainly with High Five, they're looking at community-based interventions that happen with safe routes to school, healthier transportation modes, and this is all around addressing issues like walkable communities. And so when you think about hypertension, diabetes control, that there's an overlay or an overlap there. The air quality issues, certainly some overlays and overlaps with our asthma and tobacco control policies. So CDC is, 618 is a partner with the High Five initiative, and then there is a whole body of work around that initiative that Dr. Elizabeth Skillen leads at CDC.
Great, thank you, Kristen.
Sure.
Okay, a question for Christina in South Carolina. And the question is, how did South Carolina Medicaid get involved in 618? So was it that South Carolina Public Health presented this, and then Medicaid decided to join, or was it presented by a third party? So just curious about your process for getting started in this work.
Unfortunately, I'm not able to shed a whole lot of light on that process. I came on last August, so I wasn't here for that initial car ride that is still of lore here with the staff. But I believe that both the Public Health Agency and the Medicaid agency saw information about it come across their desk, and then one or the other reached out to them. I don't believe a third party was involved, but I'm not absolutely sure.
Great, thank you. Okay, a question for both Julian in Rhode Island and Christina in South Carolina. Did either Rhode Island or South Carolina utilize information from local health information exchanges or physician electronic health records to measure the success of your 618 projects? Julian, is Rhode Island utilizing either HIEs or EHRs to track utilization or outcomes
Not for this project in particular. We do some of that with some of our other projects directly with providers and particularly with FQHCs and some of the groups across the state, part of the patient-centered medical home pediatric initiative, which we're looking at kind of general quality improvement initiatives. The intervention that we have is less focused on what happens within the clinical environment and really about providing an intervention at the community-based level, which then supports clinical care. So we have it set up in terms of providers being able to make referrals for the program. A lot of the program participants are recruited directly through Hasbro Children's Hospital and through the ER, and then recruited directly there and followed up with, and then the primary care physicians are contacted if there's an asthma action plan that's needed, and then are sent detailed feedback about what occurred at the end of the intervention. But other than that, it hasn't been directly connected in the kind of way that was mentioned.
Great. And Christina, anything to add?
Yeah, I think from our perspective, most of what we have access to most easily is the claims data, which does not always include everything that's in the EHR. But just as a flag, the quit line does have the opportunity to create an electronic referral system through a provider's EMR, even with multiple EMR vendors. And I'm not absolutely sure about whether that's a two-way process that they could capture information on DHEC's end, or if that's just helping the providers set that up so that they have access to it.
Great, thank you. So a question for Christina in South Carolina, and this question is around how you are currently working to educate or inform Medicaid beneficiaries of the new benefits that are being put into place. Can you say just a little bit more about the strategies that you're undertaking to get the word out to Medicaid enrollees about these positive changes?
Sure. So I touched on this a bit, but I'd love to elaborate a little bit more, and I'm sorry that I didn't do that previously. So DHEC has really been helpful in providing us technical assistance for the promotion of the benefits, and really we felt like the best point of contact with Medicaid beneficiaries was the managed care organizations and really having a better grasp of their populations. So rather than doing a lot of direct communication from the agency level, we're working to support the MCOs to have the capacity to do that through their communications channels, both with providers and with beneficiaries. So DHEC met with the MCO communications work group and provided background on all of the resources that they had, and now the communications work group can contact and reach out to them for additional support. Finally, the agency does have member and provider outreach teams, and so, for example, the provider outreach team might go in and do some detailing within a provider's office to describe the policy changes and also resources to help them effectively use them. And so both of those teams will have a meeting with DHEC again to receive resources and a little bit of background on how to best leverage the benefits available. So we are really grateful for their support in this area and feel like this targeted approach will help us be more effective. From DHEC's side, I think they also may be interested in their with their environmental tobacco smoke approaches, posting information in public housing locations or other areas where there may be a lot of individuals with lower income covered by Medicaid about the benefits that are available to them, both through Medicaid and with the quit line. So I think they may be leveraging that information from their end.
Great. Thank you, Christina. We have another question in that says, have you been seeing 618 utilized in Medicaid 1115 demonstration waivers? And can you talk about how getting 618 implemented might provide a grounds for DSRIP or other types of Medicaid transformation? And I can speak a little bit about that. I will say it's still, you know, the fact that 618 just rolled out at the beginning of last year, so we're still pretty early in the implementation of 618, and I think there's certainly opportunities in the future as more states think about ways to transform how Medicaid is paying for services and incorporate more prevention and population health metrics into their Medicaid work. That, you know, I anticipate seeing 618 kind of rolled into some of these statewide Medicaid waivers and strategies into the future. But one example I'll just note is one of the states we worked with in round one, Massachusetts was focused on tobacco control, and they were in the process of doing some work at the state level with a Medicaid waiver and the development of Medicaid ACOs. And I think we're work to be strategic in terms of aligning tobacco cessation metrics that they were promoting through their 618 work in some of the statewide measure sets under Medicaid that were incorporated into their waiver. I think that's one example of an opportunity is just, you know, how metrics are developed and aligned and thinking through, you know, how they fit with the 618 interventions. But I will just say overall that I think it's still pretty early and that there are lots of opportunities that we're hoping to track in the upcoming years. Okay, so now a question specifically for Julian in Rhode Island. And the question is, can the numbers you cited around return on investment of the HARP program be expected to be sustained? And then is asthma utilization, particularly of superutilizers, more inclined to be intermittent rather than consistent?
Great question. We do expect them to be sustained in some of our various levels of evaluation. We have analyzed the claims data not just in the 1 year following the intervention, but 2 years out. In that particular data set, we saw that not only did the performance of our kind of participant group outperform the control group, but then in year 2, the control group kind of increased again back to not as high a level of utilization as in the previous year, but a higher level, whereas the year 2 participant group maintained flat or had a slightly additional decrease. So we do consider it to be sustained. And part of it, I think, is because it has the kind of really intensive education and providing the tools that can be used to be able to improve the environment within the home, and really emphasizing kind of control of medication use and why the adherence to control of medication is so important, which is the real keys to maintaining, you know, sustaining long-term asthma control. And, you know, as everyone knows, asthma is a chronic disease. There is always the chance, and, you know, not everyone who goes through the intervention is completely stays out of the ER. We do see some repeat ER visits, and some patients have higher utilization levels and are more frequent flyers than others. But we have seen evidence in our evaluation of this over a number of years in a number of different ways that it can be sustained. The times that, and this is more from the evaluation side of things rather than the kind of claims data or research side, but we do see the potential, especially some of the lower income families that are constantly being displaced and moving from place to place. Then, you know, some of the families do kind of come back up again into our system a couple of years later when they're in new housing and are facing new challenges. And so we have allowed people back into the program after 2 years have passed. So not in the immediate year following, but in the year after that. And we also, the intervention that we focus on is a very kind of packaged evidence-based intervention, but we do have other interventions that we think are valuable that are part of the general comprehensive approach to asthma, including one program that is a medical-based referral to code enforcement. You know, there's certain things that are within the control and the ability of a family to be able to do themselves and to change behavior around whether it's indoor smoking, and we do see really good success for participants in either quitting smoking or no longer smoking indoors, not based on self-report data, but based on community health workers and observed data of evidence of indoor smoking. We've seen reductions in pets in the home, of stuffed animals in the room, all kinds of behavioral changes that some of which are very difficult to change, cleaning supplies, et cetera. And then there's other things that are beyond the ability of a family to do themselves and are really, especially for tenants, these are landlord responsibilities of potential code violations in the home. And so we have other programs set up to be able to support that, working with housing authorities, municipal code enforcement agencies, and others in the healthy housing world. And that we find is a really successful combination. That's not something that we're approaching healthcare or healthcare payers to be paying for. It's a separate type of intervention, but it's one that is connected and is part of what makes it a successful long-term sustained intervention.
Great, thank you. And then finally, a question for Kristen at CDC. And someone asked, what approaches have you found effective so far for engaging commercial payers who may be interested in 618 or in collaborating with Medicaid and or public health?
So really good question. So some of the, it varies very much by the commercial insurers, one might guess, but we've had some interest in asthma specifically, and interest in focusing on geographic areas where they're seeing high rates of asthma, and so that's one example. We've had interest in diabetes, and I think a lot of that, given timing and rule change and the Medicare book of business. We also have had, we've had interest across, but more specific interest in some in particular, like the asthma, diabetes, hypertension, and healthcare-acquired or healthcare-acquired infections. So that was the first part of the question. I'm sorry. There was a second part, I think. Maya, and I can't remember.
It was just any strategies for or interest that you've seen for commercial health plans to collaborate with either Medicaid or with public health?
Oh, great. Thanks. And that really great question as well. And yes, we are. We've seen some definite interest, and as I would say our work with Medicaid is probably just a step or two ahead than the work that we're doing with the commercial insurers, and so while Maya mentioned we're working with a second round of states, we're looking at an engagement with some of the commercial insurers later in the fall, and one of the interests that has been expressed by some of these commercial insurers is how they can connect, especially in certain geographic areas, with state Medicaid. And so I think that will be one of the things that really begins to evolve and develop over this next year with the work that we're doing with the commercial insurers. We've also seen that on the other side with some of the Medicaid, those interested that we're working with the states and locals on Medicaid in terms of interest with working with commercial insurers in their state. So we're seeing that across both sides of the lane, or both sides of the aisles, I should say, and looking to how we can make some connections, and in fact have had an opportunity to make some specific connections that are developing now.
Great. Thank you, Kristen. And I think we will wrap things up with one final question, which was just about if any of the current health policy debate that's going on in Washington today might impact 618. And I will just take this quickly and note that, we certainly do recognize that there is an ongoing health policy debate going on in Washington, which could certainly have an impact on many state health and healthcare activities. But I think it's safe to say that we, CHCS, and our partners on this work feel that the kind of evidence-based initiative that 618 is, that's working to improve health and control costs, warrants the continued support of federal, state, and private stakeholders. And the fact that, we see interest from all types of states and all types of stakeholders in this work really underscores our commitment to supporting evidence-based prevention. So we are certainly moving ahead and are excited to continue to engage with the current set of teams we're working with and with additional stakeholders on the 618 initiative. So with that, I want to thank you all for participating today. Hope you learned about 618, and we do encourage you to be in touch with CHCS or CDC with any subsequent questions or items you'd like to discuss with us related to our 618 work. So thanks very much, and we'll end there.